But we are fortunate in having an increasing number of new treatment options for our patients. One of them is kind of a spin off the old, and that is the new subcutaneous rituximab. We've been using vitamin R for almost 2 decades now, and it's become something in the drinking water. And now we have the opportunity, instead of the 6 hours down to 90 minutes thing, to do it 6 hours down to 10 minutes. Are you ready to adopt that for your patients?
We have already adopted this for our patients at Memorial, and we started treating patients, I think, this week or last week. So I think it's a great advancement from practical point of view. The science is still the same, the outcome is still the same. But for the patient, I think, and for hospitals and clinics, it cuts down on the time required for giving treatment significantly, which is, I think, is a major improvement.
But what I've heard is that whereas for us and for the patients, that's great. But in the community, perhaps keeping patients in the chair longer is financially more beneficial. Is that something you've heard?
I do know that, I have heard that reimbursement can be related to infusion times. I think it's hard to know how this is going to play out. There has been a shift in private practice to move infusion centers to community hospitals, so I think a lot of local doctors are no longer operating their own infusion centers. So I'm not sure, again, how that's going to affect the uptake of subcutaneous rituximab, but I'm sure we'll see things.
Yeah, I think it's a colossal advance for patients. The studies have shown doing quality of life measures that patients just love it. How is this going to be impacted by the biosimilar rituximabs that are coming out?
So, as you mentioned, there are several generic rituximab biosimilars which will be entering into the market probably in the U.S. within the next 1 to 2 years. And I think that, again, this is pure speculation, but I think that, for example, subcutaneous Rituxan or maybe other non-generic rituximabs will have to adjust their price point because if it's easier for patients and is significantly less expensive, I can't see that you're not going to see a shift in usage more towards generic products.
Yeah, there's a lot of jockeying for cost going on right now as they're moving into this arena.
One thing with the subcutaneous rituximab, there are so many of the new, or I guess novel combinations that use rituximab as a partner. And I'm wondering, how as folks that do clinical research, how do you see subcutaneous rituximab compared to infusion rituximab as a combination with novel agents? And what I'm thinking about, obviously, is a drug called lenalidomide. There is not a lot of data on subcutaneous rituximab with lenalidomide. If lenalidomide becomes a standard, is this something that people will potentially use in combination with lenalidomide?
It would make life easier for a lot of people.
I don't know.
Yeah, but there are other new drugs out there. The FDA granted accelerated approval for copanlisib, or Alicopa, for patients with relapsed follicular lymphoma. What do we have in that arena now for third-line therapy for follicular lymphoma?
Not much. So if you look at drugs approved, really not much for that space, with the exception of the oral PI3 kinase idelalisib, which was approved based on almost in a similar indication. So patients get our Benda, then our CHOP, or the other way around. And after that, there's only one agent before this one was approved, which is, as I mentioned, idelalisib, and now copanlisib is approved. People tend to use lenalidomide plus minus rituximab off-label, but by the NCCN guidelines. But once you use these agents, really not much outside clinical research that we use. So I think the addition of copanlisib is a major option that will be offered to patients who don't want or are unwilling to participate in clinical trials or don't have options to participate in clinical trials.
I'm going to make you smile. You forgot Y90 ibertumab.
I know. I did not forget them, but nobody's exactly.
See,
so exactly right. Well, no, I mean it's true. That is true. So there are 2 single agents for those who are not old enough, I guess, to remember this. So Bexar and Zevalin, that the radioimmune conjugate that unfortunately, despite the high response rate, they're not used widely anymore because of issues related to administration, toxicities, and so forth. They're good drugs. I mean, they're not used chronically. I mean, they're just like sort of like one-shot deal. But
Day one, day 8.
Exactly right. Yeah,
you're
you're done. Yeah, but this just vanished.